Good morning, and welcome to the first Patient Safety Research and Development Salon. That's part of the Pittsburgh Regional Health Initiative's Regional Autonomous Patient Safety Initiative. And my name is Robert Ferguson. I'm the Chief Policy Officer, and I will be helping to facilitate today's Patient Safety R&D Salon. And RAPS has the vision to establish Pittsburgh as a tech hub for developing autonomous technology-enabled solutions to prevent injury and harm in healthcare settings. And we think there's, of course, a lot of potential to make that happen in Pittsburgh, given all of its assets related to research, healthcare, life sciences, and autonomous technologies, and the support that exists for startups as well, and are excited that almost all of those assets are on today's salon. So the purpose of these salons, which is the first of a series, is to help stimulate a pipeline of patient safety R&D activity in the region, and to support that as well. So these salons will be designed to bring together this type of multidisciplinary group to learn about the immediate patient safety priorities, and to have a deeper understanding of the technologies that providers and patients and payers may need to prevent injury and harm in healthcare settings. They are also designed to explore the applications of the different types of technologies and big data analytics as it relates to improving patient safety. And especially, I'm excited that Dr. Sahel is here to do just that for digital twins technology. And we will also always have time to have all the participants share their interests and strengths and aspirations in terms of how you would all like to work together to develop a research team to further develop these types of solutions. And to help support that, we will also always be monitoring the types of federal grant opportunities that are available, so that you all could consider how to establish connections to ultimately apply for those types of federal grants. And there will be some discussion about that in the context of the ARPA H abstract opportunities that specifically name using technologies to improve patient safety as an area of interest. And as noted, this is the first salon of a series. So this slide includes the dates of the remaining salons throughout this year. We will be sending out an announcement to the RAPS mailing list, and also in the chat we'll be including a link so that you can go ahead and register for these future upcoming patient safety R&D salons. And we're also very excited to announce that due to support of the Jewish Healthcare Foundation, we also are announcing today a seed grant program. The request for proposals is now online, and I will include a link to this in the chat as well. And these applications are due on October 13th. There are three different categories of seed grant awards. One is up to $25,000. That's designed for startups and innovators who are interested in developing solutions for patient safety, but may need help doing some early stage learning and work as they launch their startup. The second category is up to $50,000 for a health care organization that is interested in testing or adopting a patient safety technology from a research team, a startup, or a tech group in the Pittsburgh area. That is directly in response to some of the needs that we heard from the RAPS launch event. The third category is also up to $50,000. That's a design for a multidisciplinary research teams that are also in the early stages of developing a technology idea to improve patient safety. Additional details are, of course, in the RFP, and we are here to help answer questions and to help you all form potential teams in response to this opportunity. So without further ado, just to jump into the agenda, we are honored to have Dr. Sahel here, who is the chair and distinguished professor of the Department of Ophthalmology at the University of Pittsburgh School of Medicine. He also directs the UPMC Eye Center and is the Eye and Ear Foundation Endowed Chair of Ophthalmology. Before coming to Pittsburgh and Paris, he founded and directed the Vision Institute and is known worldwide for his expertise in vision restoration techniques. And he also co-invented 40 patents, several of which have led to startup companies. And in addition to all that, we've also been very inspired by his use and application of digital twin technology to help inform diagnoses and treatment plans, using a patient-centered approach to also equip patients with that predictive foresight as part of a shared decision-making processes. Dr. Sahel, at this time, I'm pleased to hand it over to you.
Well, thank you very much for the kind invitation. So I'm going to try to share my screen and to present the work we are doing currently and our plans for the future. Do you see my slides?
Yes, we do.
Okay, very good. So thank you, everyone. And I think you may have heard already part of that, but I'll try to give you a more global picture of what we are trying to do with this digital twin project that is supported by the institution, but also by the Scheer Family Foundation, the Hillman Foundation, the Jewish Healthcare Foundation, and the Pittsburgh Foundation. It has also ramifications currently with the American Academy of Ophthalmology and others. So the idea is to leverage all the information we can gather from patients to really try to modify the pattern of care. It has to be viewed as a patient-centered approach. The technology should just be second to that priority. The goal is to build a data set that does include all the medical history and also the personal history from the patient, and be able to build a large amount of data that are relying on a large number of patients, depending on the pathology. Sometimes it can be a smaller number. For example, in rare diseases or genetic disorders, we have to rely on high quality but lower number of data points, and train that. And as you know, in the AI approach, there are several steps, and an important one is the training one before the validation one and the implementation. And the training of these models over the course of the disease are aiming at trying to obtain an assessment of predictive patterns, but more importantly, outcome measures that define the way we're going to treat future patients. So this is relying on the findings we have. The imaging in ophthalmology, we are very fortunate because we have extremely precise imaging tools. The history, the safety, the demographic, we'll get into some of these details, especially the socioeconomic patterns, because we believe that it's not possible to define the proper therapeutic plan for a patient if you don't take into account the social determinants of health. So the goal is to use the tool to develop a better clinical assessment, which means that it is an adaptive model and it's in a learning system. You are starting with the body of knowledge you have at the initial time of the therapy of the approach, and then you are enriching that over time. Of course, because everyone is very busy, it has to be efficient and it has to be adapted to the flow of the clinics. It has also to be a model that doesn't fit everyone. We have to adapt to many parameters, especially the diversity parameters. So the goal at the end of the day is really personalized medicine, which sometimes is used as a misnomer for digital medicine. And I don't think it should be the right way to describe it. It has to be a person-centered medicine. And at the core of that, safety and efficacy monitoring have to be implemented. So there are different parts to our project, and I'll describe briefly, and I'll focus on the quality part because I know this is the focus for today. The first one is the clinical analytics. So at UPMC, we are very fortunate because we have electronic medical records that have been used for over 20 years with a very large amount of data, and these are the type of information we can gather anytime we want to analyze the clinical activity. For example, this is with respect to retina. Instantaneously, we can get access to all this information, and this can help us to tackle specific questions to specific populations, but also define the parameters we are still missing that need to be obtained in the future. So this is a very adaptive tool, and at UPMC it's led by Oscar Marroquin, who is an amazing clinician, but very much involved in digital medicine with an approach that is really patient-centered. So this type of data is actually usually mostly history and the biology and things like that. But in our case, we need also to implement image analysis. And we have a large amount of images in ophthalmology. So we have to find a way to cope with this amount of information and use it in a meaningful way. Recently, we started to work initially with Google, but more recently with Microsoft on synthetic data that are compiling all the images that we are getting from patients into a synthetic model that could also in the future address issues about anonymity and the protection of privacy for patients. So the images are, I give you an example of several of the projects we were able to develop over the past few years, thanks to the support I mentioned initially. And this is led by José-Alain, Kunal Dansingani, Kiran and Sandeep in our department. We have a team now dedicated to that. The idea is to use signal processing, data science to extract the features for specific conditions. I'll give you a few examples in a short moment. Use an automated multimodal registration. Registration is a very important element because the images have to be analyzed. We are obtaining different types of sources of images and different types of data. As many of them are in 2D, some of them are in 3Ds, but more importantly, we need to assign each of the images and of the data to a specific area. So we need to register the images to align them as well as possible. It's also very important for the follow-up of patients to be able to define the progression of a lesion in a specific area of a retina, for example. And then we need to classify the different parameters to make this meaningful and adapt that to specific biomarkers for disease, because what we want to be able to monitor is the efficacy of the therapies. So this is an example of what we have been developing, but is now almost ready to be added to the clinical setting. So we get what you see on the left-hand side are 2D images that we are getting from patients. We get color from these pictures. We obtain images with different wavelengths. For example, these are red-free images where we eliminate the red light and we can get through some filters in the eye. Fluorescent angiography, which is injection of vessels, and this is obtained, you inject some dye in a vein and then you image that. We use it less and less because now we have other methods that don't require any injection. Autofluorescence, we are monitoring many types of fluorescence in the fundus that correspond to different types of molecules that are accumulating over aging or in various conditions. Then we obtain also other images that are more cross-sectional. It's called the OCT, optical coherence tomography, that is really a section of a retina. And we can add to that other types of images, for example, ultrasound images. So at the end of that, we are having a 3D type of image. Currently, there are already algorithms for reconstructing 3D images for patients. So on the right-hand side, this is what we are applying to lesions. The size of a lesion, the size of the optic nerve. We map the lesion on the fundus, and then we have a 3D assessment. This is, for example, a deposit that does accumulate in age-related macular degeneration. This is fluid that is accumulating under the retina, and this is a decision maker for several therapies that are used every day in ophthalmology. But currently, it's a very subjective assessment, and we want to provide an objective measurement that enables people to make the right decision. Is this progressing? Is this stable? Do we really need to overtreat the patient? And this is adapted to the existing technologies, but we're also developing new imaging, high-resolution imaging that is using technologies derived from astronomy, where we can have very high-resolution images. For example, what you see on this slide is a mapping of the pigment cells in the fundus. Each cell is visible. You can also map the photoreceptors, and these are the only types of neurons in the body that you can visualize in a non-invasive manner, and we can map the number of cells. So, for example, during retinal degeneration of genetic origin or during age-related macular degeneration, you can observe the loss of cells over time, and this is probably the best possible biomarker for the efficacy of any therapy. We can also monitor the blood vessels, again in a non-invasive way, and more recently we have been able to visualize inflammatory cells and to monitor the inflammation in the eye that can be observed in, of course, inflammatory diseases, infection, but also, for example, neurological disorders like multiple sclerosis, where we can see biomarkers in the retina of the evolution of a disease. This is just a sketch of the cells in the retina, but I won't get into the details. We are observing the photoreceptors, which correspond to these cells. This is on the top. The vessels, this is in the innermost part of the retina. We can also observe the ganglion cells, the ones that are forming the optic nerve, that are here. And these are very important, especially in glaucoma, but many other conditions. And we can have a very precise mapping of both the vessels and the ganglion cells. So, of course, this is very nice, but we need to be able to analyze all these images in real time. And this is where we need to build a model where all the data are being implemented into a single synthetic model data. Using the molecular information we can have, for example, the genotype, but also the biology that we can gather in the patient. So this is at the molecular level, the gene level. This is at the cellular level that we are using all the imaging I was showing to you. You can get to the tissular level. Then you can get to the global eye level where we have a biometry. We need to incorporate all the health and medical history from the patient, take into account all the psychological and the social determinants of health, and all the data we have about epidemiology of disease. So this creates a very multi-layered model, multi-dimensional model that has to be applied for each individual patient because it's a good predictor. It's a good assistance to diagnosis, but more importantly, it's a good assistance for making decisions together with the patient. At the end of my talk, I'll show you the flow that we are trying to implement for that. So we get all these levels of information that are really relying on high-resolution data collection. The other very important element, and I'll spend some time on that, is the social determinants of health. As you could see, it's positioned in this collection of data. We think, and very strong evidence for that, increasing evidence, this was ignored for many decades, but I think this is becoming absolutely conspicuous to everyone, obvious to everyone. We are in need to understand that better because it does affect, at least in the range of 50%, the outcome we are observing. And they are predictive of the access to care, the outcomes. We know that patients that are unable to come to the clinic, to come for follow-up, or to better understand because of lack of health literacy, of lack of support to get the therapies, these patients are going to have very poor outcomes. And understanding that is very important to understand the course of the disease. So what we are trying to collect, and we are doing that now in a very systematic manner in the department, is information about healthcare access, the neighborhood, what we know about the areas. We can have a precise mapping actually on the no-show and the compliance, take into account the community context, the economic stability that we can gather directly or indirectly. And we are asking patients, we are providing them when they come to the clinic with a tablet where if they are willing to, they can share with us more information about, for example, education, other parameters. So all of this is part of a model that is not something we invented. This is part of the Healthy People 2030 strategy. But we screened, and this is an application that we developed, which is applied to every patient, and it's part of the chart that we do at UPMC. So we take into account many elements. Just to give you a few examples: tobacco use, financial resources, transportation. It turns out that we have a lot of issues with transportation, stress for patients, violence, housing stability, alcohol use, food insecurity, physical activity, social connection, depression. So we can score more or less the risk factors, the activity also what patients are physically active or not sufficiently physically active. We enter that into the electronic health record, of course, taking into account the privacy from the patient. And this is something that provides an opportunity to implement in the model the social determinants of health. We have several champions in the department, and a very important one is Andrew Williams, a young faculty. I just met with him just before this meeting because we follow together a lot of elements. He's working, so he's a glaucoma specialist, an outstanding clinician, but he's also a master in public health and has been working on the social determinants of health for already a long time, although he's very young. And he's trying to understand the barriers to care in the community. And we are conducting currently a cross-sectional analysis. As you may know, we are part of a very big event that takes place every year called the Mission of Mercy, where free care is being provided, dental care, vision care now, and hearing care to around 1,500 patients over 2 days. And now we have replicated the event across the year. We started to do a smaller Mission of Mercy in different neighborhoods every 2 months. We also have a free delivery of care called Guerrilla Eye Service, led by Jake Waxman, where we are providing to people, for example, in the Biomedical clinic, also the street clinic, free care, absolute free care, and free follow-up in the department. And this is among many other events. We are also partnering with Vision to Learn, a potential way to gather a lot of information on barriers to access to care. A lot of the people we see during these events, knowing that we don't see everyone, many of them are not coming back for follow-up, although many of them have conditions that will require follow-up. So we are working on the compliance, the no-shows, and doing a very strong analysis of that. Looking at the risk factors for loss of follow-up, which is a real quality index. And we are measuring the effect of the strategy we implemented in the department. We have a patient navigator that is funded by charity for philanthropies, initially from the R&D Foundation and now from the Hillman Foundation. And this person was amazing. Last year helped single-handedly 500 people through food insecurity, housing, transportation, childcare. And now she's even in the clothing part of it to make sure that people have as much support as they get. So when the patient is not coming back for follow-up, instead of blaming the patient, we try to understand what happened and how we can help. Andrew got funding from the Research to Prevent Blindness America, from the American Academy of Ophthalmology. There is a large registry across the country with millions of patients that are being monitored, and he's trying to understand the compliance and the no-show issues. And this is just an example. I won't get into the detail. This is regarding a group of patients that are being followed and how many of them are not coming back. And we are working on how to make sure that there is no lapse of care. To give you a figure, in glaucoma, which is a treatable disease, 50% of the patients are not diagnosed, and 50% of the patients that are diagnosed are not taking the therapy. So this is one of the leading causes of blindness, but this is preventable blindness, and this is a very important quality index. Quality. So focusing on that, I know this is the main topic. We are trying to implement a strategy that is preventive versus after the fact. A lot of times quality is used to understand what went wrong. And this is certainly very important to make sure that it doesn't happen again. But I think it's even more important to be upfront and to do that ahead of time so that you don't get into a situation where you're facing quality problems. So we are reviewing, and we have a team dedicated to that I will present to you in the department. You're reviewing operational strategies, capacity, staffing, and care models, trying to identify the areas for improvement, optimize the strategies, and really reduce the number of breakdowns. So how do we do that? We have a team. Sorry for the slide. It's not very, it didn't doesn't render very well. So we have the vice chair for operation. This is my administrator, Mary Pitcher, the division administrator. So it's led by Vishal Janji, who is the vice chair for quality in the department. And we recruited a quality improvement specialist who is a practitioner who has a strong training in quality, and she's leading the effort. She's full-time dedicated to that, also supported by philanthropies, including especially what we got from the Jewish Healthcare and the Pittsburgh Foundation. But it extends actually beyond the initial target, because we realize that it's an all-encompassing strategy that she's developing. So how does it work? She's working with all the stakeholders, the patient and family, the community, the providers, and the staff. Identify the problems, try to smoothen the flow, be proactive, seek the feedback. So this is nothing original. You may have seen that many times, and see how we can develop that. So how do we do that? We are collaborating with different teams at the institutional and local level. The Vol Center for Quality at UPMC, the electronic record, and so all the data with Oscar Marroquin, the EPIC team, that is now we got a new EPIC system, which is really helping us with the flow of patient and data collection. There is a partnership with Microsoft that is proving very effective. The clinical analytics data, I mentioned Oscar Marroquin, and the enterprise architecture at UPMC, because as you know, we have a very protected system against intrusion and hacking. So all of this has to be implemented this way, and all of this is protecting patient privacy. So we look, I give you a few examples of what we have done over the past year: patient safety, surgical outcome, and clinical care. So how do we do that? We are working on the ophthalmic surgery and injections, and we are using the root cause analysis. We have a regular monthly root cause analysis ground round where we make an assessment of things that went wrong or could have gone wrong if not done properly. So to give you an example, this is what is implemented as part of a task force by the American Academy for the surgical follow-up of patients before surgery, during surgery, after surgery. And we are testing this to make sure that it is complete and it is applied across the board in the department. So we did already a review of 3 main indications: retinal detachment, macular hole surgery, and cataract surgery. And I'll share with you some of the output of that. We identified the scores of incidents and the amount of need for reoperation, for example, and detected whether there were outliers or no outliers. Fortunately, we don't have significant outliers, but also trying to understand what was the thought process behind clinical decisions during the clinic and after the clinic. So the goal is to standardize the protocol based on what we are learning, and this is now being applied to many other procedures in the department, and to implement that in the clinical documentation. So we have now this new software from EPIC, Kaleidoscope, that we are using routinely now, and is very evolutive, and it's plugged into the charts so that it's a predictor. It provides some warning. The goal is to provide some warning to the physician about potential issues in this specific situation. So we are testing it in real life. And on some of the indications, it's not fully deployed. It's really a ramping up system. We are also using it to optimize the performance in the department, the flow of the patient. We try to eliminate waiting. If you come to the new building, you'll find out that we eliminated a lot of waiting rooms just to really increase the time spent between the physician, the caregivers, and the patient, and reduce the waiting. But this requires a very good optimization of the organization. The OR utilization, the equipment maintenance, and the most important is to lead to data-driven and fact-based decision. So we are working on the resource optimization, and we are looking at all the data that we have, try to identify also shortages in resources, optimize the schedules, and use other resources just to improve. So again, this is not something from us. This is a general statement on efficacy, efficiency, and economy. But the most important is patient-centered approach. So the model is now in place, many tools that are actually working together. It's not separate. And just to see where we are going, and I'm getting to the end of my talk, in the future, continue to mine the data. So we are building this digital twin model where All of that is creating a virtual patient where we can mimic the hypothesis and present to the patient in a user-friendly, patient-friendly way the type of decisions we are proposing, alternatives to therapies, different choices, so that they can make an informed decision. The goal is to generate the model, to have predictive capabilities, implement a precision medicine and patient-centered approach, and customized care. So this is a very busy slide, but I'm going to navigate it. I mean, you may have seen it already. We start with the patient request. So this is the global twin eye project as I put it together several years ago, and we are still working on this frame, but adapting it. So the goal initially is to direct the patient to the right person. So as you know, one of the main difficulties is when patients try to get an appointment, the time it takes, but also where they are landing, what physician. So the goal is to match the request from the patient to the right people. And it doesn't have to be in the main building, the main hospital. It can be a local provider. It can even be remote medicine, depending on the complexity. So once the patient is referred to the right provider, and I don't like the word provider, but this is what everyone is using. I think caregiver for me or care sharing is probably better. So we try to prioritize, to direct, and then the patient is seen by a practitioner. The encounter is leading to an electronic record with all the data we just discussed a moment ago. These data are fed into a model that is really, the patient is agnostic to that. There is a lot of data analysis based on the information we have to create a digital twin that is used for diagnostic simulation, for decision-making, and the decision-making is based on the individual patient, based also on the experience we have from previous patients, the cohorts we have, the analytics we have, but also data that are available from evidence-based medicine. For example, the Cochrane analysis on the efficiencies and the impact of therapies. If there is already a good plan, then the plan is proposed to the patient in the patient encounter in a user patient-friendly time. If there is no good way to make a decision, there might be a potential to include the patient into a trial, provided, of course, that the patient is willing to do so. If there is no good way to decide what is the best alternative, if there is a trial that addresses this question. So the patient encounter leads to a plan. The patient makes a decision. This decision is then fed into the therapy. The therapy is provided to the patient, and there is an outcome. The outcome is going to be the one we had predicted or not the one we had predicted, better or worse. And this is going to feed the model, the data, in order to revisit the twin and for the future patient, but also for this patient to revise the model that had been built. So it's a learning system, a constantly learning system that is patient-centered and cohort-friendly, so that you can really use all of that and make sure that we can adapt that to every individual patient. Sorry, it's a very busy slide, but this is part of a global model we want to develop. The hub is the new Mercy Hospital. You're all welcome to come and visit. It's a wonderful facility, still ramping up, but really we are very happy with the resources we have and the way we are able to deliver care. But we want to do that in a much larger scale and a better quality care across the board. And patients may not have to need to travel to us. We want to bring the care where they are, and importantly, the best possible quality of care. Thank you very much.
Thank you very much, Dr. Sahel. And does anyone have any questions for Dr. Sahel before we turn the conversation over to everyone on this salon? All right, thank you again, Dr. Sahel. And one question that we wanted to ask all of the salon participants was, you just heard Dr. Sahel give some examples of patient safety applications, and we wanted to ask what ideas do you have in terms of how can digital twins be used to help make our predictions of deterioration and patient safety to help ignite a preventative action?
Yeah, this is Mike Bisich. Can you hear me?
Yes.
I'm in the waiting room because I had to see my doctor this morning. So thank you for Richard's going to fill in from the presentation on mirrors. But, you know, in a program called ENACT at the University of Pittsburgh, Sean Viswaswaran, working with family medicine, is doing a program that is kind of like digital twins in that it mines electronic health records for patients like the one the doctor is seeing in the current visit. And that plan is called Patients Like Mine. And it might be of interest because I think it does have safety implications, but it also has routine management implications, much like the pathway that Dr. Sahel presented. So there's another program at Pitt using electronic health record data to put abstracts together to help physicians make decisions about patients that has broad safety implications, drawing on actual patients with the same medications, the same symptomatology, the same medical conditions, and looking at what outcome paths look like. It's called Patients Like Mine, and it's by Sham Viswaswaran and Olga Kravchenko in the Department of Family Medicine.
So Robert, one of the things that we've been discussing about both at the Center for Machine Learning and Health and the Center for Innovation in Healthcare is the notion of utilizing digital twins for operational capacity and really understanding not just capacity within one health system, but across a particular region. So where Dr. Sahel looked at it from a sort of a micro level, looking at it from a macro level, and really trying to understand if you digitize processes, capacity, resources, those sorts of things. Could you do some mechanisms associated with predictive response if some sort of event should happen? And we just witnessed one of the largest events in our time, but there's also cybersecurity events, there's other sort of things, there's shutdown and shortages, variety of different things that you can model to understand and assess agility and resiliency within your health system.
And Seth, I know that you are also interested in the applications of digital twins, and Seth is the scientific director at Uniform Services University. Would you like to talk about your interests and the applications you see as well?
Sure. Yeah, we're much more on the research side at the Surgical Critical Care Initiative at the Uniformed Services University down in Bethesda, Maryland. Our goal is to create clinical decision support tools driven by AI modeling, but we've begun to start to incorporate digital twins into the training and test data sets that we're using with hope that this is going to improve our ability to generalize those decision support tools to other cohorts in systems outside of our training data sets, if that makes sense. So we're very nascent in this area, but we're hoping that these digital twins will help augment our ability to detect patient complications and direct care, as well as become part of a safety monitoring system, which kind of elicited my interest in this particular salon. Thank you.
And Seth's comments about monitoring and enabling teams to take a preventative action, I think also speaks to the potential use of these types of analytics in EHRs or in clinical decision support tools and even health system command centers. So I see that Kelly Robertson from Teletracking is on. Would you like to talk a bit about how you see this being incorporated into the functionality of command centers?
Yes, good morning, everyone, and thank you for having me. Can you hear me okay? Yes, okay. Command centers are, just for folks that do not know what they are, they're kind of the hub of patient flow and throughput throughout organizations. So decision to admit is made to bring a patient into the hospital, either from the ED direct admit or outside or the PACU. and you have to get them admitted timely. So the command centers are the care traffic controllers of the hospital, if you would. We do know also that there are inherent delays in getting patients from point A to point B. So I do believe that the digital twin technology and, the Dr. Sahel had mentioned access to care. It's a huge issue, and I do believe that the digital twin can probably help us highlight where the barriers are and the bottlenecks are to getting that patient from point A to point B timely. And I think it would complement the teletracking technologies.
And I think this also speaks to the need about thinking about how the end users interact with these types of technologies once they're available. And so we always get excited when we see engineers and human factors engineers as part of these calls. I see that a team from the Dallas is on. Jen, Scott, and Carolyn Johnson, would you like to bring in the human factors and engineering lens aspect of this?
Okay. Yeah. Good morning, everybody. I'm sorry, I'm just trying to. How's everybody doing this morning?
Good.
That's good. I have notes. I have notes and everything. They're gone now. Yeah, I feel like this was a really fascinating talk for a lot of reasons. Because kind of the most important thing from a human factors engineering perspective is keeping in mind, obviously patient safety, but also ease of use for practitioners, just how they're going forward with it. And this is all stuff that seemed like science fiction, 10 years ago. So it's very exciting to see these kind of learning models that are able to compile and collaborate, compile all this data and present it in a way that is useful as a tool. I feel like, as with any AI application, there is always that you have to be especially mindful that, even with a very robust and rich data set, there's always the possibility. So I think from a human factors perspective, it's good to view it as a useful tool, and maybe one day more, but it's very exciting to see what's happening in this space from a patient safety perspective, from being able to use this type of data to help diagnose and to help treat people. But there's also, we hear enough AI horror stories that it's good to, I think everybody here seems like this is a very level-headed approach to it, and a very this is a tool, this is a useful tool, and not this is the solution to all of our problems. And so I think that's a very healthy attitude to see from a human factors perspective, because I've definitely seen a lot of AI is going to save us, and it's no.
Yeah.
So yeah, very, very exciting to see all of the amazing stuff that can be done with it. I've done a little bit of looking into how digital twin technology would work from sort of a diagnosis, but looking at it as a holistic, to help decrease wait times, to help, that's fascinating. So this has been a very cool talk.
Yes, and to this point, especially Dr. Sahel's emphasis on patient-centered user design as well. And just in general, for all the participants, what else are you interested in as it relates to using AI or machine learning as it to improve patient safety?
Well, I just want to add in that, we're talking about autonomous systems, but until we get to the point, which we may never reach, that an AI can successfully handle everything from start to finish, from collecting data, analyzing and interpreting that data, deciding on a course of action, following through with that action, and then monitoring the results, there's always going to be a human element in the system, whether that is something as simple as interpreting the data or making the decision, or even just following the AI's instructions. And as long as that human component exists, there is this possibility for human error. So even as we're talking about autonomous systems, you have to keep in mind that user-centered design and keeping very close eye on the human capabilities is paramount to the success of these systems.
Right. In some ways, how this is about using technology to augment and support frontline care givers, using Dr. Sahil's term.
Yeah, this is Andrew Siegfried. Thanks for having me join. I think augmented approach from a clinical perspective is huge. I'm a pharmacist by training. I do have a healthcare technology startup focused on patient safety in the pharmacy arena, but that's the goal, right? I mean, as a pharmacist, I had a team of 13 pharmacists that reported to me, and part of my responsibility was monitoring errors and doing root cause analysis. So it really became like a passion project for me, like why these errors continue to happen and why we can't do better. And at the end of the day, I think it is, distracted, multitasking, et cetera, et cetera. So what I'm creating is a decision tool that leverages AI and NLP to really allow the pharmacist to be more clinical, right? Go from checking 500 prescriptions a day to checking 50. So there is still, Carolyn, to your point, that human error element. But when you're only focusing on the really important, the really clinical ones, and allowing the decision tool to take the low-hanging fruit, I think it does narrow and limit the potential risks. So really excited to hear about the other aspects of AI and data and really what it's going to do. So thanks for including me in today's salon.
And would anyone else like to add any additional work that you all are engaged in to help us collectively think about how these regional interests, assets can be deployed to meet the immediate needs around patient safety? Rebecca, thanks for in the comment of bringing in the intersection of social determinants of health and safety that Dr. Sahil raised as well. And she's asking, is anyone working with F2HCs in the terms of medication safety?
I think in the chat there were two questions about social determinants of health. So maybe so our strategy is not just a questionnaire we are giving to patients when they arrive, but it's using a whole set of data. Actually, we are collaborating with a health plan at UPMC on that. It's collecting information about food insecurity, neighborhoods, a lot of data. But as you can imagine, this is a work in progress. So we are just trying to pre-identify. Sometimes actually the identification of the issue occurs during the clinic or after the fact when patients don't come back, are not compliant. So there are indicators that something is going wrong. And the goal is to try to understand that the best is to be predictive so that we don't have to wait until something goes wrong to start to address it. But this is what is being done. But the questionnaire is trying to get the information that you cannot gather indirectly from the address of the patient, from the job they have, from any type of information that can be gathered just from statistical approaches. But this is the social determinants of health have to take into account many of these parameters, and food pantries, all of that is part of that. We are also working together with another team as part of UPMC and PIT on using community champions, training people that are living in neighborhoods to make sure that they are talking to people in the neighborhood and providing education and also help with any issues people could have for transportation or things like that, or just finding where to get the treatment. So this is part of it. It's a very complex issue. We are probably just scratching the surface of it, but it's certainly a major element of the inefficiencies of many therapies we have currently.
Thank you all for that excellent discussion. And at this time, I'd like to hand it over to the team at the University of Pittsburgh Department of Biomedical Informatics. And Dr. Michael Bisich, who is the chair of that department with his team, will be giving an update on some of their patient safety research and how it is working with also the CMU initiative for patient safety research team. And that team I see is on this salon as well, specifically Ari Lightman, who commented earlier, Carl Kingsford, and Alan Scheller Wolf, among others. So Dr. Bisich, I'll bring up your slides if you'd like to give that update.
Yeah, actually, because I'm in a patient waiting room and it's noisy here, Richard Boyce, who actually leads this project, is going to present, and probably the better presenter anyway. So Richard, take it away.
All right, thanks, Mike, and I hope all things go well. Can you hear us? Everybody hear me okay?
Yes.
Okay. Just a second, I gotta organize my screens just a little bit here. Okay. Just a second here. Okay, so thank you so much for allowing us to have a few minutes on this really important salon, and I think the presentations so far have been really fascinating and really just paint a picture for the great innovation that's happening here in Pittsburgh in line with the JHF's goals. With MIR, the project's long-term goal is to reduce preventable adverse events for patients who transition between the hospital and skilled nursing facilities by creating a new clinical intervention using computer-assisted medication monitoring with decision support. And the current project will develop and pilot test the novel approach. It's an exploratory project that's going to inform future work that will ultimately result in a clinical trial evaluating if the informatics support intervention helps reduce adverse drug events in nursing home patients who transition between care sites. Now, this is funding that's in conjunction with the folks with CMU on the IPSR project. And one of our big goals this year is to really foster that collaboration and execute a proof of concept data sharing mechanism that will allow CMU research to develop and test predictive and analytic models focused on patient safety and medication error avoidance on a large set of patients. Could you move the next slide, please? So our update is we started in Q2 to lay down the groundwork, which through meetings and discussions, we gathered data requirements, including the use cases and data domains that would be a part of this data sharing. We initiated and have made tremendous progress on the regulatory requirements, which include data use agreements and IRB. And we were able to wrap up and submit an important manuscript to this project, which describes failure modes that have been identified in transitions of care between the hospital, outpatient settings, and long-term care. And Q3, we're implementing the secure data enclave, and we expect to be able to provide approval to the first RAPS data projects, and establish the data set as a benchmark. And we're going to initiate work towards a letter of intent for the ARPA-H grant, which I'm going to talk about in just a minute. And Q4 will be we'll start to begin to see the development and testing of predictive analytic models using this data set, and leading to the design of a RAPS intervention to be the focus of year 2. And we'll spend much time writing the ARPA-H grant. Next slide, please. So just a little more detail on the next slide that's coming up. Just wait for a second before you shift it, on the data sharing infrastructure and how this is going to equip the CMU IPSR team and lead to some great innovation. Can we move to the next slide, please? So on this slide here, we're showing in the center is the secure enclave that has been constructed. We already have it basically constructed, and we're within a couple of weeks of beginning to open that up to users at CMU who have gone onboarded. This is a thing we're calling the RAPS Secure Enclave. It's hosted at Pitt, and you can see on the outside what's pointing into it is we have structured data from hospital and outpatient cares, which include notes. For the outpatient setting, we're collecting and bringing into the data set event logs as well. And then from post-acute care, long-term care, skilled nursing, we'll have medication labs and a regular data set collected called the minimum data set. And then we're also able to bring in home health through the OASIS project. And if you look up at the top, if you're just focusing on hospital and inpatient data, this is going to be roughly 600,000 patients that will be in the enclave, but people who have data from all the settings, there's around 3,000 patients. So it allows us to really look at different levels of transitions of care. And again, we have a set of failure modes that we're going to start off with, and certain conditions that have already well-established EHR phenotypes, so that we can begin to both generate evidence for actual decision support and start to design autonomous patient safety algorithms. Please, next slide. This is a little bit more of a technical overview of how we're setting this up. So we have 2 secure server zones, one where the data set's going to reside, that's on the right, and then on the left is the data science application server, and it's using very conventional tools that are quite widely used right now, such as Jupyter Hub and RStudio. We've also have a lot of experience working with observational health data science initiative tools, which are really well suited for retrospective observational data, that we're working with right now. And these are behind a firewall. You see the big blue line, and we're giving guest access through PIT accounts and the Global Protect VPN to the secure server zone where the CMU folks will be able to work with this data. Next slide, please. I'm going to skip that. Next. Thank you very much. So what is ARPA-H? ARPA-H is called the Advanced Research Projects Agency for Health. I've only learned about it the last few months. It's a research funding agency that supports transformative biomedical and health breakthroughs, ranging from molecular to societal. This is just quoted off their page. The span of the ARPA-H is very broad, from molecular to societal, and they put out there that they're doing streamlined awards that enable the agency to act quickly and catalyze cutting-edge biomedical and health research. So the current call for proposals is something they call an open broad agency announcement, or a BAA. And they're looking for funding proposals aiming to improve health outcomes across patient populations, communities, diseases, and health conditions. And they're looking for really breakthrough technology, these revolutionary ideas, something really paradigm shifting, something unconventional and challenging. And it's been said that this is very similar to something you might see with sort of a university technology transfer sort of a process, but then one that's a little more driving on the innovation side of things. So our plan right now in this collaboration that we have between CMU and Pitt is to work this month on deciding what the primary focus area is going to be. There's some ones that are called out in the BAA, such as proactive health or resilient systems. And then moving into August, really get down into the weeds and come up with a set of potentially revolutionary ideas that we can choose from to really target this proposal, leading in September to full-on development of that concept and engagement of partners, which we're grateful for the wonderful connections that this JHF work is bringing to this particular need. And in October, finalize the first draft of the proposed work. What's needed by the agency first is an abstract. The abstract is sort of like a mini proposal from which they'll select. But the cool thing about this is that once it's in there, they can, if they're interested in it, they'll start to work with the folks who are submitting, and they'll be back and forth between the agency and our teams if we're able to get in there. And ultimately, we'll be able to submit a full proposal in the beginning of next year. So that, I believe, concludes all the slides I wanted to present to give an update, and I really appreciate your time. Thank you.
Thank you very much, Dr. Boyce. And any questions for the Pitt DBMI MERS team, and also questions for the Initiative for Patient Safety Research team at CMU, just about their work and these opportunities that Dr. Boyce mentioned. Yep, Rebecca, I see your hand is raised.
Thank you. Thanks for hosting. Yeah, I'm wondering about all the input centers, which from, home health and hospital, outpatient, et cetera. What about in the outpatient setting, were there many medications purchased like groceries, and is that being fed into this as well?
Thank you. It's an excellent question.
You're welcome.
We have to stage the work that's been done because it's a short timeline. So we're building off of work that was done. Stephen Albert, who's on the call, working with the state on data that's being collected from folks who are on a specific insurance called PACE. So we're starting off with that data, which does have the outpatient medication orders, the inpatient medication dispensing, and we also do have the SureScripts, which is the actual electronic orders. But in terms of, and then you have also claims, at least for those people who have the insurance, but we don't have the outpatient, like what you're talking about, retail sort of scenario there. Closest we can get to that would be the SureScripts orders. But again, there's so many other feeds of data that you would desire to put into this thing. And initially we were just going to focus on what we have and then orient towards the proposal for building that out along with our partners. Because to get access to that data, you need to have access to really strong partners, like for example,
Exactly.
Yeah, that will happen. Thank you.
Yeah, that's an excellent. Thank you so much. Got to start somewhere. Agreed. I think this could be certainly a room and a project that I did when I was in school too, because I think this would be a business kind of collaborative initiative, maybe a patient safety awareness initiative. And in that realm, there are a lot of opportunities for things which are under the radar, which certainly impact patients' health. Thank you.
And interestingly, the Department of Biomedical Informatics still maintains for the state feeds from retail pharmacies and grocery stores for over-the-counter items like cough syrup and vitamins and other health-related things that people tend to get during outbreaks. So that may be leverageable down the road, but and that is still actively maintained by the department.
Right, and I think it's it doesn't have the oversight. If somebody's purchasing something as a grocery along with a tissue box or anything else, just purchased like a grocery, but no necessarily physician oversight, pharmacist oversight, or any of the multiple interactions that could be going on, and potential for safety.
And what this network that's still active is used for was to look at outbreak detection for flu season and other infectious diseases. Might be tailored, but that is a heavy lift.
Yeah, and it would certainly take a collaboration with the local pharmacy or whoever's vending this, but there are just so many places to get it. Thank you all for that.
Yeah, I would just like to add that I've been watching the chat about social determinants. For the data set that we have successfully merged this PACE program, which is a pharmaceutical subsidy effort by the Commonwealth. So we know who's in that program, and we have data from the state, and we were able to successfully match up those consumers from that state level system, which addresses a social determinant, with the UPMC EHR data.
Great. And I think there's more room to go. Again, things that are under the radar, there may be a lot more. I have volunteered for years for the Squirrel Hill Food Pantry. They do monitor their clients. They do survey. There may be a lot in pantries such as these for health and safety concerns under the radar, but still out there.
And since we've reached the top of the hour, I also just wanted to add a few comments about next steps. So to circle back to the original purpose of these salons, which are meant to spark interest, understand each other's strengths, and how we can collectively work together. Following these salons, we hope you all will connect with each other to see how those collaborations can be formed. Please don't hesitate to reach out to us at the Jewish Healthcare Foundation and Pittsburgh Regional Health Initiative in terms of how we can help establish those connections in between these salons. And the C grants, of course, are meant to help support that type of collaboration. That again will be due initially on October 13th. We will also be sending out alerts to all of the salon participants about new federal grants that relate to patient safety, technology, R&D, because we really hope as an outcome of these salons, you all will begin to submit joint proposals to in turn bring that funding into the Pittsburgh region to support patient safety R&D, which will eventually lead to the end goal of reducing and preventing injury and harm in healthcare settings. So thank you all for a great start to that journey. And as always, we'd also like to recognize Shandong Wu for helping us come up with this idea about hosting these types of salons. And we'll be in touch later today with an email announcement about the Salon series, as well as the seed grant. So have a great rest of the day, and thanks to all the presenters and to everyone who's engaged in this work.
Thank you.
Bye, everybody.